You are the nurse assessing a 19-year-old male who presents to the emergency department with chest pain. He localizes the pain to the left parasternal region, and the pain is reproducible with direct pressure. You take his vital signs and they are all within normal limits. He says that he is a very active student who frequently lifts weights, rows crew, and runs marathons. What is the most likely diagnosis? A. Peripheral vascular disease. B. Diabetes mellitus. C. Acute coronary syndrome. D. Costochondritis. E. Pulmonary embolism. The answer is D. Costochondritis. Costochondritis is an inflammation of the cartilage that bridges the sternum to the ribs. It is a very common cause of acute chest pain in young, healthy, physically active individuals without known cardiovascular disease. In this case, we have a very prototypical case, a young, physically active, especially with physical activity involving the chest like weightlifting and rowing crew, otherwise healthy male with focal, reproducible chest pain in the parasternal area, and normal vital signs on presentation. When you see this history, this is a rather convincing case for costochondritis. There is no information given that would seem to indicate a personal or family history of cardiovascular disease, and thus, costochondritis would be the best answer choice. He can be treated conservatively with NSAIDs for anti-inflammatory and pain control effects. Acute coronary syndrome, for example myocardial infarction, is very unlikely in this patient as he is young and healthy, has reproducible, focal chest pain, is very physically active, and has stable vital signs. If there was a personal or family history of cardiovascular disease, or any report of recent drug use, particularly cocaine, then this could be higher on the differential. Pulmonary embolism is very unlikely in this patient as there is no leg swelling reported, the chest pain is focal, the patient is healthy and active, and his vital signs are normal. Peripheral vascular disease would not present with chest pain, and would be highly unlikely to be present in an otherwise healthy 19-year-old. There is nothing to suggest that this healthy, active 19-year-old patient has diabetes mellitus from the information provided. You are a nurse at an orthopedics clinic. You are taking care of a football player who suffered a very painful right knee injury. You are concerned that he may have injured the unhappy triad. Which of the following correctly lists all components of the unhappy triad within the knee? A. PCL, LCL, lateral meniscus. B. PCL, MCL, medial meniscus. C. ACL, MCL, lateral meniscus. D. ACL, LCL, lateral meniscus. E. ACL, MCL, medial meniscus. The answer is E. ACL, MCL, medial meniscus. The unhappy triad is frequently injured in athletes who participate in contact sports, such as football. The injury mechanism often involves a direct, forceful hit to a firmly planted leg. The hit is forceful enough to rupture two ligaments, ACL and MCL, as well as the medial meniscus. The treatment for such an injury involves surgical intervention and a lengthy recovery period, though for patients inclined to partake in the rehabilitation process, they can often return to their desired sports after completion of surgery and rehab. You are a nurse in an emergency department and a patient presents following a bicycle accident in which he fractured his right radius and ulna. The patient complains that he cannot feel his extremity distal to the fracture. The right upper extremity is pale, painful, pulseless, and cool to the touch, and the patient complains of occasional pins and needles within and distal to the injury. You note a great deal of swelling around the fracture site. Which of the following is the most likely diagnosis? A. Limb necrosis. B. Vasculitis. C. Compartment syndrome. D. Lupus. E. Fat embolism. The answer is C. Compartment syndrome. Compartment syndrome is a surgical emergency in which an injury results in hemorrhage or swelling in an enclosed space that causes dangerously high pressures to build within the enclosed space, resulting in compromised blood flow to the muscles and nerves within and distal to the space. The symptoms include a cool, pale, pulseless extremity that may also experience paresthesis, and that is visibly swollen and tense. In this case, the patient's right arm exhibits all of these characteristics, and this presentation is highly consistent with compartment syndrome. The other choices are incorrect. Vasculitis and lupus are both autoimmune conditions that may result in limb swelling, but would be unlikely causes of this patient's presentation, especially in the setting of a recent local trauma to the affected limb. Fat embolism would not account for the patient's constellation of symptoms. There is no evidence of limb necrosis at this stage of the patient's injury. Should the compartment syndrome not be addressed and vascular flow remain compromised by persistently high pressures, then limb ischemia and consequent necrosis could be a downstream effect. What syndrome presents with pain or stiffness, usually in the neck, shoulders, and hips, which may be caused by an inflammatory condition of blood vessels such as temporal arteritis? A. Myositis. B. Guillain-Barré syndrome. C. Amyotrophic lateral sclerosis, ALS. D. Polymyalgia rheumatica. The answer is D. Polymyalgia rheumatica. Polymyalgia rheumatica is an inflammatory musculoskeletal condition that presents with pain or stiffness, usually in the neck, shoulders, and hips. Amyotrophic lateral sclerosis, ALS, is a genetic disorder of muscle wasting and neuronal death. Symptoms include progressive muscular weakness, leading to paralysis and death. Guillain-Barré syndrome is a rapid onset condition of reversible muscle paralysis and weakness following infection, most commonly Campylobacter jejuni. Myositis is a general term for inflammation of the muscles, and can be due to various causes. Duchenne's muscular dystrophy is caused by dysfunctional production of what protein? A. Dystrophin. B. Actin. C. Dystroglycan. D. Troponin. The answer is A. Dystrophin. Duchenne's muscular dystrophy, DMD, is caused by dysfunctional production of dystrophin, a protein that is part of a complex of proteins that anchor the cytoskeleton of a muscle cell to the extracellular matrix, also known as the dystrophin-associated protein complex. Its absence disrupts multiple intracellular signaling pathways, leading to muscle necrosis. Dystroglycan is another protein in this complex, but it is unaffected in DMD. Actin and troponin are also unaffected in DMD. Duchenne's muscular dystrophy has what inheritance type? A. X-linked dominant. B. Autosomal dominant. C. X-linked recessive. D. Autosomal recessive. The answer is C. X-linked recessive. Duchenne's muscular dystrophy is an X-linked recessive disease. Because of this, it is almost exclusively seen in males and rarely present in females. Girls would have to receive a recessive gene on both the X chromosome from their mother and their father. Historically, boys with a defective gene on their X chromosome rarely lived past their teens, decreasing the likelihood of reproduction. What antibodies are present in 90% of patients presenting with myasthenia gravis? A. Antibodies to acetylcholinesterase receptor. B. Antibodies to acetylcholine receptors. C. Anti-dsDNA, double-stranded DNA, antibodies. D. Anti-uro antibodies. The answer is B. Antibodies to acetylcholine receptors. Myasthenia gravis is a condition in which the immune system makes antibodies to acetylcholine receptors, thus blocking receptors and preventing the stimulating effect of acetylcholine at the neuromuscular junction. This results in muscle weakness that progresses during activity and improves with rest. Anti-uro antibodies are commonly seen in Sjogren's syndrome and systemic lupus erythematosus, SLE, and anti-dsDNA antibodies are highly specific for SLE. What condition is characterized by a deficiency of normal type 1 collagen, resulting in the formation of brittle, fragile bones? A. Marfan syndrome. B. Osteogenesis imperfecta. C. Legg-Calvé syndrome. D. Ehlers-Danlos syndrome. The answer is B. Osteogenesis imperfecta. Osteogenesis imperfecta is a genetic condition characterized by a deficiency of normal type 1 collagen, resulting in the formation of brittle, fragile bones. Bones fracture easily, often with no obvious trauma. Osteogenesis imperfecta has many subcategories that range in severity, several of which are not compatible with life. Ehlers-Danlos syndrome is a collagen abnormality that primarily affects the skin, joints, and vasculature, causing lax joints and general instability. Marfan syndrome is also a condition of connective tissue abnormality, which largely affects the structure and function of smooth muscle in the cardiovascular system. Legg-Calvé syndrome is a condition of necrosis in the femoral head, not related to any alterations in collagen formation. The rehab nurse provides care to an immobilized patient. He bears weight down on the patient's leg while the patient attempts to lift that leg. What type of exercise is this? A. Active assistive range of motion. B. Isometric. C. Active range of motion. D. Active resistive range of motion. E. Passive range of motion. The answer is D. Active resistive range of motion. Active resistive range of motion is performed by the client against resistance, manual or mechanical. This exercise builds muscle strength. Isometric exercises are performed by the client without motion, rather, the client contracts and relaxes the muscle without moving the joint. This maintains strength in the muscle while the joint is immobilized. Passive range of motion is performed by the nurse without assistance from the client, which retains circulation and range of motion in the joint. Active range of motion is performed by the client without assistance of the nurse and maintains joint mobility and muscle strength. Active assistive range of motion is performed by the client with help of the nurse to increase motion in the joint. In the emergency department, the nurse evaluates a patient with severe pain in the left calf after falling during a soccer game. Which of the following is the most appropriate action by the nurse? A. X-ray the calf. B. Give morphine. C. Apply heat to the calf. D. Notify the physician. E. Bandage the calf. The answer is A. X-ray the calf. The nurse should begin assessment to determine the cause of the complaint. Obtaining an X-ray for the leg is the best assessment. You need to rule out possible fracture before giving pain medication or bandaging the leg. Heat is inappropriate for this injury because ice is best for sports injuries such as sprains and breaks. Notifying the physician may be done after all assessments are completed. The nurse evaluates a patient's status post-right hip replacement and observes a moderate amount of serous drainage on the dressing 1 day after the surgery. Which of the following is the best action? A. Leave the dressing alone to let the wound heal. B. Notify the doctor about possible infection. C. Change the dressing and clean the site with normal saline. D. Replace the dressing and document. E. Remove the dressing and leave the wound open to air. The answer is D. Replace the dressing and document. 24 hours after surgery, surgical wounds are expected to drain small to moderate amounts of serous or serous drainage. The physician does not need to be notified because this observation is expected and not emergent. However, the doctor would be notified if drainage exceeds these expectations. The soiled dressing should be removed and replaced with a new dressing, and the wound site would not be irrigated unless infected. There are no signs of infection noted. The wound should not be open to air due to the risk of infection. The nurse should always document wound appearance and dressing changes. The nurse prepares discharge information for a 70-year-old woman recently diagnosed with osteoporosis. Which of the following information is most essential for the nurse to share with the patient? A. A recommendation for a doctor that specializes in bone pain. B. An information sheet for acetaminophen use. C. A pamphlet about physical activity and daily exercise for people with osteoporosis. D. A flyer for a soccer program. E. A brochure about opiate medication use. The answer is C. A pamphlet about physical activity and daily exercise for people with osteoporosis. Osteoporosis is common among elderly women. Patients require important education on how to live with the disease. Lifestyle changes such as diet and exercise should be promoted by the patient during discharge, and should be specific to the patient's condition. Of the available options, the most accurate and essential information for the nurse to share should concern physical activity and exercise, as osteoporosis affects bone density and body strength. A recommendation for a doctor that specializes in bone pain may be beneficial, but is not a responsibility of the nurse. Education is the priority. Patients with osteoporosis that are being discharged usually take ibuprofen to manage pain, not opioids or acetaminophen. A soccer program may not be appropriate for a 70-year-old woman with osteoporosis. A flyer for an adult walking group might be better. All of the following are common findings in osteoarthritis except A. Stiffness and pain in affected joints. B. Bony protuberances of affected joints. C. Symmetrical joint involvement. D. Asymmetrical joint involvement. The answer is C. Symmetrical joint involvement. Osteoarthritis generally presents as asymmetrical joint stiffness and pain, often with bony protuberances, osteophytes, that are either palpable or visible on imaging. Symmetrical joint involvement is more typical in rheumatoid arthritis. Joints will present with signs of inflammation, redness, heat, pain, and swelling, due to the inflammatory nature of this condition. A positive anterior drawer test of the knee would be indicative of injury to which of the following structures? A. Lateral collateral ligament. B. Posterior cruciate ligament. C. Medial collateral ligament. D. Anterior cruciate ligament. The answer is D. Anterior cruciate ligament. The anterior drawer test of the knee checks for injury to or instability of the anterior cruciate ligament. During this test, the patient lies supine position with knees bent to 90 degrees. The practitioner sits on the both feet of the subject and places both hands around the upper tibia of the patient's symptomatic leg, then pulls anteriorly on the proximal tibia. A positive finding would be excessive anterior translocation or a softened feel, indicating a sprain or tear of the anterior cruciate ligament. Lambert-Eaton syndrome is associated with what malignancy? A. Gastric carcinoma. B. Colon cancer. C. Small cell lung cancer. D. Melanoma. The answer is C. Small cell lung cancer. Approximately 60% of individuals with Lambert-Eaton syndrome have small cell lung cancer. The onset of Lambert-Eaton symptoms often precedes the detection of the cancer and should be followed up with radiographic imaging of the chest. A postmenopausal female client presents to the client after being newly diagnosed with osteoporosis. The client is here to discuss with the nurse what type of lifestyle modifications she will need to treat the disease. Which of the following should the nurse include when educating the client? A. Start a low carbohydrate high protein diet. B. Quit smoking. C. Lose 10 pounds. D. Drink 1 glass of wine with dinner. E. Engage in low impact exercises. The answer is B. Quit smoking. Smoking and alcohol ingestion are risk factors for developing osteopenia or osteoporosis. These activities should be discontinued to help prevent against bone loss. Diet and exercise are important factors, but losing 10 pounds or low impact exercise will not increase bone mass. The nurse cares for a 16-year-old patient in the emergency department. He has returned to the hospital after having a fiberglass cast applied to his right ulna from a fracture the day before. Which of the following manifestations in the patient should most concern the nurse? A. Warm fingers and palm in the right hand. B. Capillary refill of 3 seconds in the right fingertips. C. Itching under the cast. D. Severe pain in the right arm. E. Pain in the right shoulder. The answer is D. Severe pain in the right arm. The nurse should be aware of potential complications of cast placement, such as compartment syndrome, which can cause nervous, vascular, and muscle damage. Signs and symptoms include tingling distal to the cast placement, severe pain in the casted region, swelling in the cast and distal to the casted region, pallor in the affected region, and muscle weakness. These signs and symptoms would indicate immediate cast removal to prevent further damage to the tissue. Itching under the cast is common and expected, and pain in supporting shoulder of the arm can occur due to the increased weight and positioning of the cast. 3 seconds for capillary refill is within normal limits. Extended time for capillary refill in the distal region would be concerning. Warmth in the hand and fingers distal for the casted region would indicate normal circulation as well, but congestion and swelling in the extremity would be worrisome. Which of the following is described as a malformation resulting in narrowing or absence of a portion of the intestine? A. Malrotation. B. Intestinal atresia. C. Volvulus. D. Hirschsprung's disease. The answer is B. Intestinal atresia. Intestinal atresia is a malformation resulting in narrowing or absence of a portion of the intestine. Duodenal atresia is the most common type, followed by ileoatresia. Hirschsprung's disease is an issue of innervation in the large intestine that can result in narrowing due to contraction, but there is no structural malformation in the bowel itself. Malrotation and volvulus are often seen together when a part of the intestine does not anchor or turn correctly during formation, malrotation, and then becomes twisted around itself, volvulus, resulting in constriction and loss of function. What is the triad of symptoms often seen with intussusception? A. Bloody vomit, black stool, and low back pain. B. Colicky abdominal pain, bilious vomit, and red currant jelly stool. C. Constipation, projectile vomiting, jaundice. D. Coffee ground emesis, bloating, and diarrhea. The answer is B. Colicky abdominal pain, bilious vomit, and red currant jelly stool. Intussusception occurs when part of the intestine folds into another section of intestine, much like a telescope. This results in sharp, crampy, or colicky abdominal pain, vomit of bile, and bloody red currant jelly stool. Black stool and coffee ground emesis are both symptoms of upper gastrointestinal bleeding, stomach, generally, while projectile vomiting may be associated with pyloric stenosis. What is the most common location for diverticulitis? A. Ascending colon. B. Transverse colon. C. Splenic flexure. D. Sigmoid colon. The answer is D. Sigmoid colon. The most common location for diverticulitis is the sigmoid colon. This area generally has increased pressure as compared to the rest of the large intestine and is especially vulnerable to weakness in the muscle layers of the colon wall. What part of the bowel is most often affected by Crohn's disease? A. The terminal ileum. B. The sigmoid colon. C. The ascending colon. D. The rectum. The answer is A. The terminal ileum. While Crohn's disease can affect any part of the alimentary canal, the small intestine, particularly the terminal ileum, is the most common site of serosal inflammation. What is the characteristic mucosal alteration seen in ulcerative colitis? A. Thickened mucosa. B. Skip lesions. C. Cryptabscess. D. Granulomas. The answer is C. Cryptabscess. The characteristic histological alteration seen in ulcerative colitis is the cryptabscess, in which inflammation causes loss of goblet cells due to neutrophilic exudate in glandular lumens. Granulomas, thickened mucosa, and skip lesions are all seen in Crohn's disease. Frequent projectile, non-bilious vomiting starting 2 to 3 weeks after birth is indicative of what condition? A. Intussusception. B. Infant gastroesophageal reflux disease, GERD. C. Congenital hypertrophic pyloric stenosis. D. Diverticulitis. The answer is C. Congenital hypertrophic pyloric stenosis. In congenital hypertrophic pyloric stenosis, the smooth muscle of the pylorus becomes thickened, decreasing the lumen size of the pylorus. This prevents food from passing out of the stomach and into the small intestine, resulting in vomiting which is often projectile and tends to be non-bilious. Intussusception may show vomiting, but the more obvious sign is bloody currant jelly stools. Infant gastroesophageal reflux disease, GERD, may result in frequent spitting up, but projectile vomiting is rare. Diverticulitis is generally a condition of the elderly and tends to present as abdominal pain with alterations in bowel function and mild fever. What comorbidity is generally seen with esophageal varices? A. Gastroesophageal reflux disease, GERD. B. Achalasia. C. Hiatal hernia. D. Cirrhosis. The answer is D. Cirrhosis. Esophageal varices are most commonly seen in patients with cirrhosis due to portal hypertension. Gastroesophageal reflux disease, GERD, is associated with esophagitis and occasionally with metaplastic changes. Neither hiatal hernia nor achalasia are associated with esophageal varices. What sign might indicate Hirschsprung's disease in a newborn? A. Unrelenting crying. B. Bloody stool 3 to 5 days after birth. C. Vomiting within 48 hours of delivery. D. Failure to pass meconium within 48 hours of delivery. The answer is D. Failure to pass meconium within 48 hours of delivery. While an infant with Hirschsprung's disease may have vomiting and bloody stool, the most common sign is failure to pass meconium within 48 hours of delivery. Hirschsprung's disease, which is an absence of innervation to the large intestine, which results in narrowing and constriction of one part of the bowel and dilation of the preceding segment, can be diagnosed by biopsy of the distally narrowed segment of the bowel. What tissue of the gastrointestinal tract is affected in celiac disease? A. Stomach, causing gastritis. B. Rectum, causing fistulation. C. Large intestine, causing ulceration. D. Small intestine, causing villus atrophy. The answer is D. Small intestine, causing villus atrophy. While individuals with celiac disease can certainly have gastritis, fistulas, and ulceration due to inflammation, the primary effect of celiac disease is villus atrophy in the small intestine. Villi become blunted, leading to loss of ability to absorb nutrients, including minerals and fat-soluble vitamins. Which of the following refers to bleeding from partial thickness tears in the mucosa at the junction of the stomach and esophagus? A. Esophagitis. B. Barrett's esophagus. C. Boerhaave's syndrome. D. Mallory-Weiss syndrome. The answer is D. Mallory-Weiss syndrome. Mallory-Weiss syndrome refers to bleeding from partial thickness tears in the mucosa at the junction of the stomach and esophagus, often from traumas such as violent retching or coughing. This is compared to Boerhaave's syndrome, which is a full thickness tear of the esophageal wall. Esophagitis is most commonly caused by gastroesophageal reflux disease, GERD, and does not present with bleeding. Barrett's esophagus refers to a type of metaplasia in the lower esophagus which is thought to be caused by chronic GERD. Full thickness, transmural, ulceration of the bowel wall occurs in what condition? A. Ulcerative colitis. B. Crohn's disease. C. Celiac disease. D. Irritable bowel syndrome. The answer is B. Crohn's disease. Full thickness, transmural, ulceration of the bowel wall occurs in Crohn's disease. Bowels may also show thickened walls, serosal adhesions, and loss of the regular folds. In ulcerative colitis, ulceration is restricted to the gut mucosa. Celiac disease results in blunting of intestinal villi, but does not cause ulceration in any form. Irritable bowel syndrome, or IBS, is considered a functional disease as it results in no known pathological tissue changes. Janelle is a 56-year-old woman who is 3 days post-total abdominal hysterectomy. She has not passed gas or had a bowel movement since before surgery. The patient starts vomiting dark brown material. The nurse should be sure to do which of the following? A. Administer antiemetics. B. Auscultate for bowel sounds. C. Report the finding to the next shift. D. Have the patient lay on her left side. E. Place a cool washcloth on the patient's forehead. The answer is B. Auscultate for bowel sounds. The patient is displaying symptoms that could indicate a paralytic ILS. A paralytic ILS is a blockage of the intestine that may result after surgery, most commonly abdominal surgery. During an ILS, the intestine cannot move food through the bowel. A patient with this condition will not have bowel sounds. Constipation, nausea, and vomiting are all considered symptoms of an ILS. The nurse is caring for an 89-year-old male who has been admitted for nausea and vomiting. His treatment plan consists of IV fluid replacement of 0.9% normal saline at 150 ml per hour, IV ondansetron PRN, IV prochlorperazine PRN, and an NPO diet. The patient starts to show signs of confusion. The nurse may suspect which of the following? A. New onset of Alzheimer's disease. B. The patient's antiemetics. C. The IV fluid replacement rate. D. The NPO order. E. The IV fluid composition. The answer is B. The patient's antiemetics. Older adults are at high risk for the development of side effects related to medication use. Antiemetics are commonly administered medications and may cause confusion, especially in older adults. The nursing student cares for a patient newly diagnosed with inflammatory bowel disease, IBD. He decides to review the different types of IBD, ulcerative colitis and Crohn's disease. Which of the following statements is not true about these types of IBD? A. Ulcerative colitis usually manifests with fatty stool, steatorrhea. B. Complications of Crohn's disease include fistula formation and intestinal obstruction. C. Ulcerative colitis and Crohn's disease may occur in very young children. D. Complications of ulcerative colitis include hemorrhage, abscess formation, and arthritis. E. Crohn's disease presents with weight loss, anemia, and dehydration. The answer is C. Ulcerative colitis and Crohn's disease may occur in very young children. Ulcerative colitis has a usual age of onset from 20 to 30 and 50 to 80 years old. Patients with UC have frequent fatty stools with occasional rectal bleeding and abdominal pain after eating. Nurses who care for patients with UC must consider possible intestinal obstruction and fistula formation in these patients. Crohn's disease has a usual age of onset from young adults to middle-aged, 30 to 50 years old. Patients with Crohn's disease did not have fatty stools but do have common rectal bleeding that may lead to hemorrhage. These patients experience pain before defecating and will have 10 to 20 liquid, usually bloody, stools per day. Nurses who care for patients with Crohn's disease should consider possible abscess formation and arthritis. Both UC and Crohn's disease present with weight loss, anemia, and dehydration due to ineffective nutritional absorption through the intestinal tract. Nurse is discussing with a 56-year-old male client causative factors that have led to his development of peptic ulcer disease. The nurse realizes that there is need for further teaching when the patient makes which of the incorrect statements? A. I will eat several small bland meals daily, and avoid irritating foods such as raw fruits and vegetables. B. I will take my prescribed triple therapy with antibiotics and proton pump inhibitor to eliminate the H. pylori infection for 2 months as instructed by my physician. C. I will quit smoking, as I understand nicotine contributes to the development of gastric ulcers. D. I am aware that I should engage in relaxation techniques to minimize stress, to help reduce the acid my stomach produces. E. I will avoid certain medications such as aspirin, NSAIDs, and corticosteroids. They are capable of disrupting the stomach lining. The answer is B. I will take my prescribed triple therapy with antibiotics and proton pump inhibitor to eliminate the H. pylori infection for 2 months as instructed by my physician. The treatment for peptic ulcer disease when the bacterium H. pylori is found to be present has several treatment strategies. These strategies include a triple drug therapy consisting of a proton pump inhibitor, amoxicillin and clarithromycin. This combination of drugs should be continued for 7 to 14 days, 2 months is not the course of treatment. All other statements are consistent with proper teaching of causative factors associated with peptic ulcer disease. A nurse is retrieving a report from a hepatic biopsy in a patient with an acute hepatitis B infection. The report describes swollen hepatocytes with irregularly clumped cytoplasmic organelles and large clear spaces. This is known as which of the following? A. Ascites. B. Ballooning degeneration. C. Fibrotic changes. D. Necrosis. The answer is B. Ballooning degeneration. Ballooning degeneration is a form of hepatocellular apoptosis, rather than necrosis, in which hepatocytes swell and begin to show irregularly clumped cytoplasmic organelles and large clear spaces. It is a severe condition often seen with viral hepatitis or steatohepatitis. It is distinct from fibrotic changes, in which depositions of collagen fibers are seen on histology. Ascites is a collection of fluid in the peritoneal cavity, rather than a histological feature. Which of the following is not a response normally seen in liver disease? A. Necrosis. B. Inflammation. C. Intracellular accumulation. D. All of these are commonly seen in liver disease. The answer is D. All of these are commonly seen in liver disease. The liver generally responds to injury in the following ways: inflammation, necrosis or apoptosis, degeneration leading to accumulation of intracellular deposits, fibrosis, and regeneration. Some of these, such as inflammation and mild degeneration, are reversible. Other changes, such as severe degeneration and fibrosis, may be permanent. You are assessing a patient complaining of 3 days of fever, crampy abdominal pain and profuse, watery, mucoid, non-bloody diarrhea. The patient recently completed a course of clindamycin after having her wisdom teeth removed. The patient has not eaten any raw foods, red meats, shellfish, seafood, or greasy foods recently, and has not had any recent travel. What is the most likely cause of her diarrhea? A. Clostridium difficile. B. Cryptosporidium parvum. C. Escherichia coli. D. Shigella dysenteriae. E. Salmonella typhi. The answer is A. Clostridium difficile. The most likely cause of this patient's diarrhea is Clostridium difficile, also known as C. diff. Clostridium difficile typically causes watery, non-bloody, mucoid diarrhea, associated with fever and abdominal pain, most commonly in patients who have completed a recent course of antibiotics. In the past, it was thought that clindamycin was the most frequent antibiotic-related cause of C. difficile, but recent studies have shown that other classes of antibiotics, including cephalosporins, are associated with comparable rates of C. difficile diarrhea. In this patient, the characteristics of her diarrhea, associated symptoms, and recent antibiotic exposure are most consistent with C. difficile as the cause of her diarrhea. Escherichia coli exists in multiple subtypes, but often is associated with bloody diarrhea after eating undercooked red meats, ecdiarrhea, or watery diarrhea after traveling to a foreign, undeveloped country, ectech diarrhea. This patient's history is not consistent with E. coli infection. Salmonella and Shigella diarrhea are each typically bloody. This patient's diarrhea is non-bloody. Cryptosporidium parvum diarrhea is often watery, as is the case in this patient, but it frequently occurs in immunosuppressed patients, is typically not mucoid, and does not have a known temporal association with taking antibiotics, as does C. difficile. You are the nurse taking care of a patient who is receiving ibuprofen for back pain, and the patient complains of burning epigastric pain after swallowing his ibuprofen pills for the last few days. You suggest which of the following to the patient? A. Try taking the pills without any water. B. Try taking the pills with a full glass of water. C. Take the pills right before lie down you go to sleep. D. Request the pills more frequently. E. Try taking the pills while lying down. The answer is B. Try taking the pills with a full glass of water. Bilesophagitis is an irritation of the esophagus that can occur after a patient takes certain medications orally. Bilesophagitis is caused both in part by local, direct damage to the esophageal mucosal lining from the pill itself, as well as from, depending on the particular drug, the systemic actions of the drug. In this patient's case, he takes ibuprofen, which can both damage the esophagus lining directly, and also predispose to poor mucosal repair from its systemic effects. There are a number of interventions to remediate bilesophagitis. If the medication can be changed to an equivalent drug that has less of a known propensity to cause bilesophagitis, that is a valid option. In addition, as in this case, you can encourage the patient to take the pill with a full glass of water, as this helps increase the odds of the pill traveling the full distance of the esophagus to the stomach, and not getting caught in the esophagus, causing localized damage and esophagitis symptoms. Taking the pills while lying down would be an inappropriate intervention, as this increases the risk of the pill getting stuck in the esophagus, causing localized esophagitis symptoms. The same reasoning applies for taking the pill right before lying down for bed. Taking the pills without any water would also decrease the odds of the pill fully traveling down the esophagus to the stomach, and therefore increases the odds of experiencing bilesophagitis symptoms. Requesting more of the pills without addressing how the patient is taking the pills would be inappropriate, as they appear to be inciting the esophagitis pain. You are the nurse taking care of a patient with dull epigastric abdominal pain that is new since returning from vacation 3 weeks ago. He was recently on vacation to India where he did not have any dietary restrictions. Fecal occult blood testing stool cards revealed occult blood in the patient's stool. He does not have any associated diarrhea, weight loss, hematemesis, or other symptoms. Which of the following is the most likely cause of the patient's abdominal pain? A. Pancreatic cancer. B. Traveler's diarrhea. C. Peptic ulcer disease. D. Malnutrition. E. Aortic dissection. The answer is C. Peptic ulcer disease. The patient's symptoms in studies: dull epigastric abdominal pain, FOBT occult positivity, as well as the time course relative to his vacation to a developing nation, 3 weeks removed from travel to India, are each quite consistent with peptic ulcer disease. Peptic ulcer disease is rather rare in developed countries, as the causative organism, Helicobacter pylori, has essentially been eradicated in developed countries. However, in developing countries, such as Mexico or India, which are frequently traveled places by Americans, patients can be exposed to H. pylori in the food and water supply there, which can then begin to grow in the patient's gastrointestinal tract. As a result, it can predispose the patient to peptic ulcer formation, which would present, as in this patient, with a dull epigastric abdominal pain, discomfort as well as dried or occult blood in the stool. The patient does not have any diarrhea or lower abdominal pain that would suggest traveler's diarrhea. There is no evidence that the patient is malnourished from the information provided. While vague, dull, gnawing abdominal pain is a potential sign of pancreatic cancer, peptic ulcer disease is a more likely etiology of this patient's abdominal pain given its time course relative to his travel to India. There is no evidence to suggest that this patient is experiencing an aortic dissection, as that is often described as tearing back pain. You are the nurse taking care of a 22-year-old female who complains of increased frequency of loose non-bloody, non-mucoid stools for 3 days. She notes that her eating habits have not changed recently, she has not traveled outside of the United States recently, she has no known sick contacts, no family history of colon cancer, and does not take any medications on a daily basis. She notes that her job has become increasingly stressful over the last 5 days, and that in the past, when her job or relationships have become stressful, this has triggered abdominal cramps, and diarrhea that is temporarily relieved with bowel movements. She currently is febrile, with a normal white blood cell count, and vital signs within normal limits. Which of the following is the most likely diagnosis? A. Irritable bowel syndrome, IBS. B. Gluten intolerance. C. Colon cancer. D. Ulcerative colitis. E. Lactose intolerance. The answer is A. Irritable bowel syndrome, IBS. IBS is a gastrointestinal condition characterized by abdominal pain or cramps, as well as acute episodes of diarrhea and or constipation that is often triggered by psychological stressors such as depression or anxiety, or a preceding gastrointestinal infection. IBS is more common in young females than other demographics, and often can be comorbid with clinical depression or anxiety disorders. Its pathophysiology has not yet been fully characterized. There is no definitive diagnostic test to confirm a diagnosis of IBS, but the lack of blood or mucus in the stool, as well as the lack of a fever or elevated white blood cell count, all are consistent with a diagnosis of IBS. Further, in this patient, given that she is a young female whose symptoms for this episode and prior episodes coincided with psychological stressors and resolved with bowel movements in resolution of her stressors, and who also had no fever, elevated white blood cell count, vital sign abnormalities, or concerning historical details, foreign travel, dietary changes, sick contacts, IBS is the most likely diagnosis. Ulcerative colitis would be more likely to present with recurrent episodes of bloody and or mucoid diarrhea, as opposed to non-bloody, non-mucoid diarrhea. Further, given this patient's relationship of symptoms to immediate psychological stressors, her symptoms are more consistent with IBS than ulcerative colitis. Colon cancer would be an unlikely diagnosis in a young, otherwise healthy patient with no family history of colon cancer. The fact that she is experiencing non-bloody, non-mucoid diarrhea does not in and of itself provide evidence for colon cancer. Colon cancer may present with occult blood in the stool, melanotic stools, or blood-streaked stools, but would be highly unlikely in a healthy young patient. Gluten intolerance and lactose intolerance are reasonable thoughts when evaluating a young, otherwise healthy patient with non-bloody, non-mucoid diarrhea. Lactose intolerance would likely present at a younger age though, and the patient's diet reportedly has not changed prior to her diarrhea episodes, which would argue against a dietary etiology of her diarrhea. Further, given the close relationship of her symptoms to acute psychological stressors, IBS is the most fitting diagnosis. You are the nurse taking care of a patient who underwent a total abdominal hysterectomy 36 hours ago. The patient states that they have not passed flatus or had a bowel movement since the surgery. You reassure the patient that this is common following surgery, for which of the following reasons? A. Postoperative amphetamines. B. Postoperative ILS. C. Viral infection. D. Fungal infection. E. Bacterial infection. The answer is B. Postoperative ILS. In the presented scenario, the patient is just 36 hours removed from a total abdominal hysterectomy, which is an invasive abdominal surgery. During a hysterectomy, the patient typically receives inhaled anesthesia, as well as opioid pain medications, which each individually can result in a postoperative ILS. Furthermore, given that there is manipulation of abdominal organs in accessing the uterus, simple mechanical manipulation of the bowels during surgery can be enough to result in a postoperative ILS. For each of these reasons, postoperative ILS is a common occurrence, and is the most likely cause of this patient's lack of passing of flatus or feces. There is no reason to think that this patient received postoperative amphetamines. Furthermore, if the patient did receive amphetamines, that would likely stimulate the digestive tract, rather than inhibit its activity. Neither bacterial, viral, nor fungal infections would be likely causes of lack of flatus or feces passage following a surgery. These infections would be more likely to cause loose stools, diarrhea, rather than an ILS. You are the nurse taking care of a 2-week-old firstborn male child. His parents brought him to the emergency department because he has been projectile vomiting for the last 5 days. On physical exam, you note a palpable olive within the upper abdomen, and lab work shows a hypochloremic metabolic alkalosis. Which of the following is the most likely diagnosis? A. Toxic megacolon. B. Pyloric stenosis. C. Type 2 diabetes mellitus. D. Achalasia. E. Esophageal tumor. The answer is B. Pyloric stenosis. This is a congenital condition that most commonly affects firstborn male infants. Pyloric stenosis is a congenital narrowing and excessive tightness of the pyloric sphincter, resulting in difficulty passing food from the stomach to the duodenum in the infant. As a result, the child frequently forcefully vomits until a surgical intervention reduces the tone of the pyloric sphincter. On physical exam, a palpable olive can sometimes be felt within the upper abdomen, representing the pyloric sphincter. On lab work, due to the potassium and chloride lost in the vomited material, a hypochloremic metabolic alkalosis can be observed. On occasion, there is a history of the mother having taken erythromycin antibiotics during gestation. Esophageal tumor is highly unlikely in a newborn, as both of the most common types of esophageal tumors typically occur in patients 50 and older. Achalasia would present as difficulty swallowing, rather than as frequent vomiting of stomach contents. In achalasia, The food cannot pass beyond the esophagus, whereas in pyloric stenosis it cannot pass beyond the stomach. A palpable olive would not be felt in achalasia. Type 2 diabetes is extremely unlikely in an infant, and would not likely present with gastroparesis as its first symptom. Cirrhosis is a chronic disease that affects which organ? A. Liver. B. Kidney. C. Heart. D. Small intestine. The answer is A. Liver. Cirrhosis is a chronic liver disease, usually caused by alcoholism. It is characterized by fibrosis and destruction of the normal liver tissue. Patients who have cirrhosis may have hepatomegaly on physical exam, which is enlargement of the liver. For example, it may be felt on the abdomen. Which of the following describes a calcium carbonate preparation? A. Rapid acting, releases carbon dioxide in the stomach, causing belching and flatulence. B. Rapid onset and liberates carbon dioxide, increases intra-abdominal pressure and promotes flatulence. C. Slow acting, contains significant amounts of sodium. D. Rapid acting, is also a saline laxative. The answer is A. Rapid acting, releases carbon dioxide in the stomach, causing belching and flatulence. Calcium carbonate preparation is rapid acting, releasing carbon dioxide in the stomach, causing belching and flatulence. Calcium carbonate is an antacid which reacts quickly with HCl to form calcium chloride and carbon dioxide. Which of the following does the nurse not recognize as a medication regimen for treating Helicobacter pylori infections? A. Triple therapy metronidazole, omeprazole plus clarithromycin. B. Dual therapy ranitidine bismuth citrate plus clarithromycin, omeprazole plus clarithromycin. C. Quadruple therapy colloidal bismuth subnitrate, tetracycline, metronidazole plus omeprazole. D. Single therapy colstipol. The answer is D. Single therapy colstipol. Multiple therapies are required to treat Helicobacter pylori infections. Colstipol is a bile acid sequestrant used to lower blood cholesterol, which is not used to treat Helicobacter pylori infections, a bacterium that colonizes the human stomach. What foods must be avoided in celiac disease? A. Foods containing gluten. B. Foods containing dairy. C. Foods containing red meat. D. Foods containing oat. E. Foods containing wheat. The answer is A. Foods containing gluten. Celiac disease is an autoimmune condition that is triggered by ingestion of gluten, a protein found in wheat, barley, and rye. A wheat-free diet is not sufficient for a patient with celiac disease, as many other products contain elements of barley or rye and thus also contain gluten. Oat, while often avoided by individuals with celiac disease due to cross-contamination during processing, does not contain gluten. Whole dairy products are also generally gluten-free and considered safe for patients with celiac disease. Samantha is a registered nurse working in the intensive care unit with a patient recently diagnosed with Clostridium difficile. She violates Clostridium difficile contact precautions by A. Donning only gloves and a gown before entering the room. B. Placing the client in a semi-private room with another patient diagnosed with Clostridium difficile. C. Placing the patient in a private room. D. cleansing her hands with only alcohol-based gel before leaving the room. E. Cleaning surfaces with hypochlorite-based disinfectants. The answer is D. Cleansing her hands with only alcohol-based gel before leaving the room. Clostridium difficile, C. Diff, is an infection caused by Clostridium difficile bacteria and requires contact precautions. Contact precautions state that nurses must wear gloves and a gown while caring for the patient. Nurses must also perform adequate hand hygiene before and after the use of gloves. Additionally, because C. Diff infections are caused by spores, alcohol gel alone may not be sufficient to eliminate the bacteria. Current practice is the use of soap and water to cleanse hands. Afterwards, nurses may utilize alcohol-based hand gel. It is acceptable to place a C. Diff patient in a semi-private room with another C. Diff patient if private rooms are unavailable. Carrie is caring for an 85-year-old woman in a long-term care facility. Her patient has been taking antibiotics for the past 2 weeks to treat a severe case of cellulitis. Carrie notices that her patient has developed a fever, has refused her last 2 meal trays, and is complaining of abdominal pain. Which of the following samples should Carrie seek permission to obtain? A. A blood sample. B. A sputum sample. C. A gastric fluid sample. D. A urine sample. E. A stool sample. The answer is E. A stool sample. It is possible that this patient is suffering from a Clostridium difficile infection caused by bacteria. The presence of an underlying condition, increasing age, and antibiotic use are all risk factors for contracting Clostridium difficile. A stool sample is commonly used to test for the bacteria. Until the results are available, Carrie should place the patient under proper C. difficile contact precautions. A female client with advanced cirrhosis of the liver has noticed that her abdomen has become greatly distended and she is concerned about her body image. The client asks the nurse, "What is causing my stomach to look so big?" The nurse responds based on her knowledge of liver disease and possible signs and symptoms. She tells the client which of the following explanations for her distended abdomen. A. Cirrhosis is highly associated with severe constipation and the accumulation of gas in the peritoneal cavity causing distension. B. An accumulation of nitrogen waste in the bloodstream due to the liver's inability to transform the waste to non-toxic substances causes ascites. C. The liver is producing excess cholesterol and it has accumulated in the interstitial spaces of the abdomen. D. The liver's inability to make clotting factors due to vitamin K deficiency causes internal bleeding into the cavity. E. Elevated blood pressure in the liver and the liver's inability to synthesize albumin causes fluid shifts in the abdomen. The answer is E. Elevated blood pressure in the liver and the liver's inability to synthesize albumin causes fluid shifts in the abdomen. Portal hypertension causes proteins to move from the bloodstream into the lymphatics which cannot handle the excess and they leak into the abdominal cavity. The proteins causes an osmotic pressure pulling fluid into the space leading to ascites. Hypoalbuminuria will lead to decreased colloid oncotic pressure as well, also contributing to ascites. Which of the following bacterial species is responsible for the development of peptic ulcers? A. Treponema pallidum. B. Viridans streptococci. C. Staphylococcus aureus. D. Streptococcus faecalis. E. Helicobacter pylori. The answer is E. Helicobacter pylori. Helicobacter pylori or H. pylori is the bacterial cause of peptic ulcers. Staphylococcus aureus is a bacteria that frequently causes skin infections along with other conditions such as toxic shock syndrome. Streptococcus faecalis is responsible for many urinary tract infections, and contracting viridans streptococci may result in endocarditis. Treponema pallidum bacteria cause syphilis. The nurse is caring for a 25-year-old patient diagnosed with a poorly functioning lower esophageal sphincter. The nurse may advise the patient to do which of the following? A. Avoid alcoholic beverages. B. Limit water intake. C. Lay down immediately following meals. D. Avoid ingestion of antacids. E. Avoid whole grains. The answer is A. Avoid alcoholic beverages. Several foods can cause relaxation or irritation of the lower esophageal sphincter. Alcohol, carbonated beverages, and chocolate are a few examples. Advise the patient to remain upright after meals, to utilize antacids when appropriate, and to practice a balanced diet. Which of the following GERD medications works by neutralizing stomach acid? A. Famotidine. B. Magnesium hydroxide. C. Pantoprazole. D. Ranitidine. E. Omeprazole. The answer is B. Magnesium hydroxide. Magnesium hydroxide is a strong base. It works by neutralizing the acid in the stomach, forming water and magnesium chloride. All other listed medications work to prevent the stomach from overproducing acid, rather than neutralizing the existing acid in the stomach. Which of the following patients is most at risk for the development of a hiatal hernia? A. An 80-year-old obese male who loads trucks for work. B. A 35-year-old pregnant woman with a gastrointestinal tumor. C. An obese male who smokes cigarettes. D. An 80-year-old obese woman with alcohol-related ascites. E. A 30-year-old male professional athlete. The answer is D. An 80-year-old obese woman with alcohol-related ascites. Advanced age, female sex, obesity, alcohol abuse, frequent heavy lifting, pregnancy, gastrointestinal tumors, and smoking may increase an individual's risk for the development of a hiatal hernia. The correct scenario represents 4 risk factors. The nurse cares for a patient with appendicitis. Which of the following positions is best for improving breathing and relieving abdominal pain? A. Trendelenburg. B. Reverse Trendelenburg. C. Fowler's. D. Side lying. E. Sims. The answer is C. Fowler's. Fowler's position, head of bed, HOB, elevated 45 degrees, increases comfort, ventilation, circulation, and relieves pressure from the thorax. It would be best for this patient due to the pain experienced by the patient in the abdomen. Sims position, halfway between lateral and prone, upper arm flex, lower arm behind patient, is used when a patient is receiving an enema or an examination in the perineal area. Trendelenburg, HOB lowered, feet elevated, is used for patients with hypotension, as it promotes venous return. Reverse Trendelenburg, HOB elevated, feet lowered, is used to promote gastrointestinal problems by minimizing esophageal reflux. Side lying, patient on side with top leg in front of bottom leg and hip, knee flexed, is used to relieve pressure from the sacrum and is often rotated with patients who are on bed rest. A 35-year-old client is being discharged post-hemorrhoidectomy surgery. The nurse is explaining in detail all discharge instructions to be followed for a successful post-operative period. The client will need to adhere to which of the following instructions? A. Avoid pain medications post-procedure as they may cause constipation. B. Avoid bowel movements until sutures are removed. C. Use of daily enemas to promote frequent bowel movements. D. Take oral pain relievers prior to bowel movement to reduce discomfort. E. Use of rectal suppositories in place of oral stool softeners. The answer is D. Take oral pain relievers prior to bowel movement to reduce discomfort. To prevent pain during a bowel movement post-operatively, pain medication is often indicated to help make it more tolerable. Pain medications will need to be given post-op and may contribute to constipation, but oral stool softeners and a high-fiber diet can help to avoid the constipation. Rectal suppositories and daily enemas are not needed. Bowel movements should not be delayed nor avoided in the post-operative period. A client is being treated on the medical surgical unit for pneumonia and has recently developed severe diarrhea. Upon cultures performed, it has been determined the client is now carrying Clostridium difficile, C. diff, and will need to be on special precautions to prevent the spread of this disease. All of the following are consistent with the appropriate precautions when dealing with those infected with C. difficile except A. All persons having direct contact with the client will wear a mask, including healthcare workers and visitors. B. Healthcare providers, as well as visitors, will put on gloves and wear a gown over their clothes while interacting with clients with C. difficile. C. Hospital rooms and medical equipment that have been used for clients with C. difficile must be disinfected and cleaned thoroughly. D. When possible, client will occupy a private room or share a room with another C. difficile client. E. All healthcare persons interacting with the client will wash their hands with soap and water or alcohol rub prior to contact. The answer is A. All persons having direct contact with the client will wear a mask, including healthcare workers and visitors. This client is to be on contact precautions. The wearing of a mask is consistent with airborne precautions, which is not necessary for C. diff. All other choices are appropriate for contact precautions. Overdose of which of the following over-the-counter medications is one of the leading causes of liver failure in the United States? A. Diphenhydramine. B. Acetaminophen. C. Loratadine. D. Cimetidine. The answer is B. Acetaminophen. Acetaminophen causes more liver failure in the United States than viral hepatitis, making it one of the most common causes of liver-related emergency room visits. It causes approximately 78,000 emergency room visits and 150 deaths due to liver failure each year. None of the other medications listed are associated with liver failure. The majority of hepatic infections are with which of the following type of microbe? A. Bacteria. B. Fungi. C. Prions. D. Viruses. The answer is D. Viruses. The majority of liver infections are viral in nature. Hepatitis A, hepatitis B, and hepatitis C are the most frequent agents of infection, with hepatitis C being the leading cause of liver transplants. Bacterial infections in the liver most commonly take the form of an abscess. Fungal hepatitis and prion infection of the liver are not generally seen. Which of the following viruses can cause hepatitis? A. Yellow fever. B. Cytomegalovirus. C. Epstein-Barr. D. All of these. The answer is D. All of these. There are multiple viruses that can cause hepatitis other than hepatitis A, B, or C. Among these are Epstein-Barr virus, cytomegalovirus, and yellow fever. You are the nurse for a new patient brought to the emergency department for a suspected gastrointestinal bleed. The patient is tachycardic and hypotensive, but conscious, responsive, and breathing spontaneously without any airway trouble. Which of the following is the best initial intervention? A. Insert 2 large bore peripheral IVs. B. Prepare to intubate the patient. C. Administer hydromorphone. D. Administer lorazepam. E. Administer warfarin. The answer is A. Insert 2 large bore peripheral IVs. This patient is suffering from a suspected gastrointestinal bleed, and based upon the report of the vital signs, he is hemodynamically unstable. In evaluating an emergency trauma patient, the ABCs must be assessed: A. Airway, B. Breathing, C. Circulation. In this patient's case, it is stated that he is responsive and breathing without any issues, indicating that his airway and breathing are both satisfactory. The next issue is his circulation. Given that he has a suspected bleed, and is tachycardic and hypotensive, it is likely that he is losing a significant amount of blood from his bleeding viscera. As such, he may need emergent, rapid fluid and/or blood product resuscitation. The best way to prepare for this immediately is to place 2 large bore peripheral 4 lines, such that resuscitation can be provided through these lines while the rest of the workup and treatment continues. Any delay in placing these lines delays the fluid, blood resuscitation of the patient, which can be dangerous. At this point, given that the patient has a protected airway and is breathing without issue, intubation would not be indicated. Should his airway or breathing status change, the need can be reassessed. Administering hydromorphone, a potent opioid, may be necessary if the patient is in a significant amount of pain, but that would not be the most pressing initial concern given that he is hemodynamically unstable. Administering warfarin, an anticoagulant, would be highly contraindicated in this patient, as he likely has an active gastrointestinal bleed and is hemodynamically unstable. Administering lorazepam, a benzodiazepine, is not indicated in this hemodynamically unstable patient with a suspected gastrointestinal bleed. After stabilization and continued demonstration of airway protection, if the patient is anxious, this need can be reassessed. You are the nurse taking care of an 83-year-old patient with a history of gastroesophageal reflux disease, GERD. They complain that they are having heartburn symptoms at night when trying to go to sleep and in the morning when they wake up. In addition to addressing their medical therapy options, you recommend which of the following to the patient? A. Do not take calcium carbonate for symptomatic relief. B. Avoid spicy foods before going to bed, but otherwise eat a whole meal right before going to bed. C. Eat your last meal at least 3 hours prior to going to bed, and sleep as upright as possible, with multiple pillows. D. Eat immediately prior to going to bed. E. Drink 1 cup of coffee prior to going to bed. The answer is C. Eat your last meal at least 3 hours prior to going to bed, and sleep as upright as possible, with multiple pillows. This recommendation involves fairly simple lifestyle changes that have the potential to greatly decrease the patient's symptom burden. Heartburn symptoms can be exacerbated in patients who eat spicy foods, at any time, who drink coffee, and/or who eat meals shortly prior to going to bed, since the food can physically reflux back to the distal esophagus from the stomach prior to being digested more completely. Thus, any of those recommendations would be inappropriate. Further, in a patient who is acutely experiencing acid reflux symptoms, it is typically appropriate for them to take calcium carbonate to neutralize the acid and relieve symptoms. As such, advising the patient to not eat immediately prior to going to bed, and to remain upright, to physically minimize reflux of contents, would be the most appropriate recommendation. You are a nurse at an oncology infusion center taking care of a 45-year-old female with breast cancer, currently being treated with chemotherapy. While receiving her chemotherapy infusion, she complains of severe nausea. Which of the following medications would be most appropriate to treat this patient's nausea assuming she has a normal QTc interval? A. Acetaminophen. B. Ketorolac. C. Ibuprofen. D. Meloxicam. E. Ondansetron. The answer is E. Ondansetron. This patient, who is actively being treated with chemotherapy and experiencing severe nausea, is most likely suffering from chemotherapy-induced nausea. The most appropriate first-line treatment for chemotherapy-induced nausea in a patient with a normal QTc interval is ondansetron, also known as Zofran. Ondansetron is a serotonin 5-HT3 receptor antagonist, likely accounting for its anti-nausea properties. A side effect is QTc interval prolongation, and as such, careful consideration as to whether or not to prescribe ondansetron should be given for patients with baseline prolonged QTc intervals. Acetaminophen, an analgesic, would not treat nausea, nor would ibuprofen, meloxicam, or ketorolac, all NSAID medications. You are the nurse at a primary care clinic taking care of a 40-year-old male who is undergoing his routine annual well check. His only complaint is that about once per month, when eating spicy food or drinking significant amounts of alcohol, he experiences heartburn. Which of the following would be the most appropriate recommendation? A. Take over-the-counter omeprazole daily for 1 year. B. Go to the nearest emergency department immediately, as this could be indicative of a heart attack. C. Take over-the-counter ranitidine daily for 1 year. D. Take 1 to 2 tablets of calcium carbonate every 3-6 hours as needed for heartburn symptoms, and if you symptoms more frequently or severely, return to clinic. The answer is D. Take 1 to 2 tablets of calcium carbonate every 3 to 6 hours as needed for heartburn symptoms, and if you experience symptoms more frequently or severely, return to clinic. This patient is apparently healthy 40-year-old male whose only complaint is very infrequent heartburn that occurs in response to specific trigger foods and drinks, spicy foods and alcoholic beverages. In a patient who experiences mild to moderate heartburn, or acid reflux, symptoms infrequently, meaning less than 3 times per week, the appropriate initial recommendation is to take over-the-counter calcium carbonate tablets as needed, as these will directly neutralize the excess acid in the distal esophagus and stomach. For the majority of patients with infrequent heartburn brought on by known trigger foods and beverages, this will be sufficient to provide symptomatic relief. It is inappropriate in a patient with infrequent heartburn who has not yet tried, and failed, calcium carbonate to initiate ranitidine or omeprazole treatment, as these are more potent methods to suppress intrinsic stomach acid production, and are not necessarily required to provide symptomatic relief for these patients. If the patient in this example was experiencing more frequent heartburn, More severe heartburn, or heartburn that was not adequately controlled by calcium carbonate, then ranitidine or omeprazole would be reasonable options. The best initial treatment option for a patient with heartburn is not acetaminophen, an over-the-counter analgesic. Heartburn is caused by reflux of acidic gastric contents into the distal esophagus. The best initial treatment for an acute episode of heartburn is calcium carbonate, as this will directly neutralize the acid that is causing symptoms, and provide symptomatic relief for most patients. It would be inappropriate to send this patient immediately to the emergency room as he is not currently experiencing heartburn symptoms. His symptoms are highly consistent with heartburn, as opposed to a cardiac etiology, given that they are brought on only infrequently and directly in response to trigger foods and beverages. If the patient was actively complaining of chest pain, and more concerning aspects of his pain were elicited that suggested a cardiac etiology, then an immediate referral to an emergency department would be a more valid consideration. A client presents to the clinic for fecal occult blood testing, FOBT, as part of his colorectal screening appointment. The nurse previously instructed this patient to avoid certain foods for 48 to 72 hours prior to testing. All of the following foods were to be avoided except A. Turnips, B. Prunes, C. Beets, D. Red meat, E. Cantaloupe. The answer is B. Prunes. There are many foods not to be ingested just prior to FOBT. Prunes are fine to eat. Red meat, broccoli, cantaloupe, beets, turnips, carrots, horseradish and several others may alter the test results and should be avoided before a FOBT. A 70-year-old female client is being treated as an outpatient for diverticulitis. The nurse explains that there are several complications associated with this disease. The nurse informs the patient that diverticulitis is the most common cause of what complication? A. Renal failure. B. Severe diarrhea. C. Bowel obstruction. D. Peritonitis. E. Lower gastrointestinal bleeding. The answer is E. Lower gastrointestinal bleeding. Diverticulitis is the most common cause of lower GI bleeds. Peritonitis and bowel obstruction are possible complications, but not most commonly associated with diverticulitis. Renal failure and severe diarrhea are not complications of diverticulitis. The pediatric nurse assesses an 11-year-old patient in the emergency department. The child's parent explains the child's signs and symptoms from the last few days. Which of the following statements by the parent is most important to the nurse? A. He was complaining about a strong pain in his stomach, on the right side above his hip. B. He has a fever around 99.5 degrees Fahrenheit and has thrown up a few times. C. He has been feeling this pain for the 2 days, but it suddenly went away. D. When he walks, he holds his arm around his stomach. E. He hasn't been eating very much since the pain started. The answer is C. He has been feeling this pain for the 2 days, but it suddenly went away. This patient is experiencing signs of appendicitis, which include periumbilical abdominal pain, usually originating in the right lower quadrant, anorexia, nausea, vomiting, localized tenderness, muscle guarding, and a low-grade fever. Appendicitis is frequently diagnosed in young children and young adults with these symptoms and a white blood cell count from 15,000 to 20,000 cells per cubic millimeters. The nurse should be most concerned if the pain has suddenly ceased, which may be a sign of perforation, which is an emergency due to hemorrhage and infection risks. The pediatric nurse cares for a young child admitted with appendicitis. Which of the following signs and symptoms most concerns the nurse? A. Distended abdomen and abdominal rigidity. B. White blood cell count of 18,000,16,000, and 17,000 cells per cubic millimeters over 3 days of hospitalization. C. Temperatures of 99.6 degree Fahrenheit, 99.2 degree Fahrenheit, and 99.4 degree Fahrenheit on the shift. D. Tenderness of the abdomen in the right lower quadrant. E. Anorexia, nausea, and vomiting. The answer is A. Distended abdomen and abdominal rigidity. Without treatment, appendicitis can lead to peritonitis or perforation. Typical signs and symptoms of appendicitis include periumbilical abdominal pain, anorexia, nausea, vomiting, localized tenderness, muscle guarding, and low-grade fever. The normal WBC count for a patient with appendicitis ranges from 15,000–20,000 cells per cubic millimeters. The nurse caring for a patient with appendicitis should always be aware of particularly concerning signs or symptoms of peritonitis, especially those that differ from established baseline signs and symptoms. Many of the symptoms of appendicitis may be apparent with peritonitis, especially tenderness, fever, and white blood cell counts. When assessing for peritonitis, the nurse should specifically look for abdominal rigidity or distension, rebound tenderness, increased, severe abdominal pain, ascites, increased temperature, increased leukocytosis, and paralytic ILS. What is the incubation period of hepatitis B, HBV? A. 1 to 2 weeks. B. 2 to 4 days. C. 1 to 6 months. D. Up to 2 years. The answer is C. 1 to 6 months. Hepatitis B has a long incubation period. From the time of initial infection, symptoms might take from 1 to 6 months to appear. A patient just returned from a trip outside of the country and is now experiencing fever, nausea, and vomiting. She tests positive for hepatitis A IgM. She would like to know if hepatitis A is a chronic infection, or if it will resolve with treatment. The nurse should advise her which of the following? A. Hepatitis A is not a chronic disease and it does not exist in a carrier state. Once the infection is resolved, you will no longer have hepatitis A. B. Hepatitis A becomes chronic in 25% of cases. Monitoring for viral DNA should be repeated every 6 months. C. Hepatitis A becomes chronic in 75% of cases. Monitoring for viral DNA should be repeated every 6 months to 1 year, but you will likely always carry the disease. D. Hepatitis A generally does not become a chronic infection, but you will always be a carrier of the disease. The answer is A. Hepatitis A is not a chronic disease and it does not exist in a carrier state. Once the infection is resolved, you will no longer have hepatitis A. Hepatitis A is a generally benign, self-limiting disease that does not develop into a chronic hepatitis. It also cannot exist in a carrier state. Once the virus is cleared by the immune system, the individual will no longer carry the virus or be infectious to others. Hepatitis B can be transmitted via any of the following routes except A. Blood. B. Stool. C. Vaginal fluids. D. Semen. The answer is B. Stool. Hepatitis B is primarily transmitted via blood, vaginal secretions, and semen. While the virus is often present in saliva, it is not generally spread by sneezing, kissing, or sharing utensils, unless there are oral abrasions resulting in a mutual exchange of blood. The virus does not have fecal-oral transmission. A patient with pancreatitis is placed on an NPO order. What does this order mean? A. The patient cannot walk. B. The patient cannot eat only. C. The patient cannot drink only. D. The patient cannot eat or drink. The answer is D. The patient cannot eat or drink. NPO means is a Latin phrase meaning nothing by mouth. This order is used when a patient is not allowed to eat or drink any substances, usually due to a disturbance within the GI tract or if they are scheduled for a surgery. NPO orders are common in the ICU and surgical setting. A client with Crohn's disease is asking the nurse how to accomplish a low residue, low fiber diet. The nurse will tell the client to avoid A. White bread. B. Cooked potatoes. C. Refined pasta. D. Apples. The answer is D. Apples. Crohn's disease is an indicator for a low residue, low fiber diet. The diet should include foods that are unlikely to obstruct the intestinal tract if narrowed by inflammation or scarring, or if gastrointestinal motility is slowed. The home health nurse visits the home of a patient who has just been discharged from the hospital after a small bowel resection. Which of the following patient statements concerns the nurse? A. I enjoy eating cornbread with my dinner. B. I drink a lot of apple juice. C. I make my sandwiches with white bread and smoked turkey. D. I limit the amount of milk I drink to 1 glass each day with breakfast. E. I have stopped drinking coffee every day. The answer is A. I enjoy eating cornbread with my dinner. Patients recovering from lower bowel surgery, such as small bowel resection, must adhere to a low residue diet to minimize intestinal activity. A low residue diet includes white breads, cereals, and pastas, well-cooked vegetables without skins, fresh fruits without peels or seeds, tender and well-cooked meats, limited dairy, meat broths and strained soups, and clear juices. The patient must avoid high residue foods, including whole grain breads such as cornbread, strong cheeses and yogurt, raw vegetables, dried fruits or legumes, juices with pulp, coffee or other caffeinated beverages, popcorn, nuts, and seeds. Which of these is a proper lifestyle change to fight gastroesophageal reflux disease, GERD? A. Cessation of soda intake. B. Decreasing fluid intake. C. Eating acidic foods. D. Increasing spicy food intake. E. Eating meals less than 1 hour before bedtime. The answer is A. Cessation of soda intake. Soda intake exacerbates symptoms of GERD. Along with this, individuals should wear loose clothing, exercise regularly, drink plenty of fluids, avoid eating within 1 to 2 hours of bedtime, and avoid spicy and acidic foods. A nurse is counseling a 60-year-old woman who recently found out that she has chronic hepatitis C. She is not sure how she became infected, though she does state that she had a blood transfusion in 1989 due to postpartum hemorrhage. She is concerned about the stigma of the disease and wonders how common it is in the United States. The nurse informs her of which of the following? A. Hepatitis C is the most common chronic blood-borne infection in the U.S. 3.9 million Americans have had or are currently infected with the virus. B. Hepatitis C is the third most common chronic blood-borne infection in the U.S. 2 million Americans have had or are currently infected with the virus. C. Hepatitis C is a rare infection. There are currently approximately 30,000 people in the United States living with this disease. D. Hepatitis C is not particularly common. Approximately 300,000 people in the United States have a current or past infection with the virus. The answer is A. Hepatitis C is the most common chronic blood-borne infection in the U.S. 3.9 million Americans have had or are currently infected with the virus. Hepatitis C is the most common chronic blood-borne infection in the U.S. Approximately 3.9 million Americans have antibodies against the virus. Of those, approximately 70%, 2.7 million, have chronic hepatitis C infections. Most pituitary adenomas are non-functional, incidentalomas. Of the functional adenomas, which are the most common? A. Null cell adenoma. B. Prolactinomas. C. Gonadotrophic adenomas. D. Somatotrophic adenomas. The answer is B. Prolactinomas. Prolactinomas, prolactin secreting, make up 30% of functional pituitary adenomas. The second most common type are somatotrophic, growth hormone secreting, adenomas, which make up 15%, followed by gonadotrophic, gonadotrophin releasing, adenomas, which make up 10% of reported cases. Null cell adenomas are non-functional, they do not secrete hormones. Which of the following are common cardiac signs with hyperthyroidism? A. High cardiac output, tachycardia, and atrial fibrillation. B. Diastolic murmurs and low cardiac output. C. Atrial stenosis and tachycardia. D. Premature ventricular contractions and low cardiac output. The answer is A. High cardiac output, tachycardia, and atrial fibrillation. A cardiac workup on a patient with hyperthyroidism will often reveal high cardiac output, tachycardia, atrial fibrillation, a prominent, fourth heart sound, S4, and full murmurs. This condition is not associated with low cardiac output, and while it may be seen with murmurs, it is not specifically associated with atrial stenosis. What HbA1c level is diagnostic for type 2 diabetes? A. Greater than 6.5%. B. Greater than 5.7%. C. Greater than 6.3%. D. Greater than 7.0%. The answer is A. Greater than 6.5%. A hemoglobin A1c level of 6.5% or greater is considered diagnostic of type 2 diabetes. A HbA1c level of less than 6.5% does not exclude a diagnosis of diabetes, however, and should be looked at alongside fasting blood glucose and oral glucose tolerance testing. What is the most common cause of hyperthyroidism? A. Hashimoto's thyroiditis. B. Toxic nodular goiter. C. Graves' disease. D. Thyroid storm. The answer is C. Graves' disease. Graves' disease is the most common cause of hyperthyroidism. Graves' disease is an autoimmune condition in which antibody is produced against the thyroid-stimulating hormone, TSH, receptor, which binds to receptors, resulting in continuous stimulation of the gland to synthesize and secrete excess quantities of the thyroid hormones T4 and T3. Thyroid storm and toxic nodular goiter are less common causes of elevated thyroid hormone levels. Hashimoto's thyroiditis is the most common cause of hypothyroidism. What is the most common sign of primary hyperparathyroidism? A. Elevated serum phosphorus. B. Depressed serum calcium. C. Elevated serum calcium. D. Depressed serum potassium. The answer is C. Elevated serum calcium. The most common manifestation of primary hyperparathyroidism is elevated serum calcium. Parathyroid hormone, PTH, activates osteoclasts, which mobilize calcium and phosphate from bone. PTH also increases renal tubular absorption of calcium and inhibits the reabsorption of phosphate, resulting in elevated blood calcium levels while maintaining normal phosphate levels. High PTH has no significant direct effect on potassium levels. A male client presents to the outpatient clinic for care for recently diagnosed hyperparathyroidism. He has been undergoing care for this condition. The nurse recognizes this patient will be at risk for several clinical manifestations. All of the following are signs and symptoms associated with hyperparathyroidism except dash. A. Skeletal pain and backaches. B. Painful muscle cramps and tremors. C. Delirium and confusion. D. Kidney stones and urinary tract infections. E. Shortened QT interval on ECG. The answer is B. Painful muscle cramps and tremors. Painful muscle cramps and tremors are associated with low calcium levels, which is indicative of hypoparathyroidism. All the other choices are associated with high calcium levels and therefore are symptoms associated with hyperparathyroidism. A 35-year-old male client presents to the emergency department after wife found him unresponsive at home. The wife informs the nurse her husband is a diabetic, and had not taken his insulin for the past 2 days. The client appears flushed, breathing is rapid and deep, and has a fruity smell on the breath. The nurse suspects this presentation is diabetic ketoacidosis, which diagnostic finding would confirm this pathology. A. Elevated blood urea nitrogen, BUN. B. Serum bicarbonate of 23 milliequivalents per liter. C. Blood glucose 450 mg per deciliter. D. Decreased serum osmolality. E. Blood pH of 7.26. The answer is E. Blood pH of 7.26. The acidic pH is what is most consistent with the diagnosis of diabetic ketoacidosis, DKA. A pH of less than 7.30 is what is seen in DKA. The blood glucose will be elevated, but the nurse may also see a similar elevation in hyperosmolar hyperglycemic syndrome as well. The serum bicarbonate will be low and the serum osmolality would be elevated, yet both findings are not specific for DKA. Elevated BUN, blood urea nitrogen, is not specific for DKA as well. The nurse cares for a patient with a history of diabetes mellitus after a cholecystectomy. He has reported nausea and cannot have solid foods. Upon assessment, the patient appears disoriented and confused. Based on these observations, Which of the following is the most likely explanation for the patient's condition? A. Diabetic ketoacidosis. B. Insulin resistance syndrome. C. Hypoglycemia. D. Hyperglycemia. E. Diabetic hyperglycemic hyperosmolar syndrome. The answer is C. Hypoglycemia. A patient's status post-surgery is often unable to eat due to nausea. A diabetic patient is likely to be suffering from hypoglycemia because of this. Confusion, disorientation, and shakiness are common manifestations of hypoglycemia as well. Hyperglycemia may present with blurry vision, frequent urination, headaches, and fatigue. Diabetic ketoacidosis can manifest with thirst, frequent urination, weakness, and fruity scented breath and occurs in patients with diabetes mellitus, DM, type 1. Diabetic hyperglycemic hyperosmolar syndrome may also present with the same symptoms of diabetic ketoacidosis but occurs in patients with DM type 2. Insulin resistance syndrome, also known as metabolic syndrome or prediabetes, usually does not present with manifestations, but people with severe insulin resistance syndrome may present with dark patches of skin on the back of the neck, elbows, knees, and/or armpits. You are taking care of a 66-year-old female who complains of weight gain, lethargy, dry skin, hair loss, constipation, and increased cold sensitivity. Based upon this assessment, you feel that the most likely diagnosis is which of the following? A. Diabetic ketoacidosis. B. Thyroid storm. C. Hyperthyroidism. D. Diabetes insipidus. E. Hypothyroidism. The answer is E. Hypothyroidism. This patient's constellation of symptoms is most consistent with hypothyroidism. In hypothyroidism, which may occur for a handful of reasons, the patient typically does not produce significant levels of thyroid hormone, T3/T4, and therefore, a variety of functions that are modulated by thyroid hormone are impaired. Common symptoms associated with hypothyroidism are weight gain, lethargy, hair loss, brittle hair, dry skin, constipation, depression, cold sensitivity, bradycardia, and brittle nails, among other symptoms. On exam, the patient's thyroid may feel enlarged. Characteristic lab findings would be an elevated TSH level with low or low, normal T3/T4 levels. The other choices are incorrect for the following reasons. 1. Hyperthyroidism would be characterized by opposite symptoms from those seen in this patients. Patients with hyperthyroidism would be tachycardic, anxious, have poor heat tolerance, diaphoretic, may have diarrhea, and weight loss among other symptoms. 2. Thyroid storm is a severe, life-threatening condition that is essentially an acute, severe manifestation of excess levels of thyroid hormone, also known as thyrotoxicosis, and presents with very pronounced, severe signs of hyperthyroidism. 3. Diabetic ketoacidosis is almost exclusively seen in patients with diabetes, which is not noted in this patient, and often presents with diffuse abdominal pain, rapid shallow breathing, altered mental status, and a fruity odor on the breath. 4. Diabetes insipidus would present with increased frequency of urination of dilute urine, fatigue, enuresis, dehydration, and/or electrolyte abnormalities. You are the nurse taking care of a 23-year-old patient who complains of anxiety, diaphoresis, palpitations, diarrhea, weight loss, and tremors. When examining them, you notice exophthalmos and eyelid lag. The most likely diagnosis in your patient is which of the following? A. Diabetes insipidus. B. Graves' disease. C. Hypothyroidism. D. Glucagonoma. E. Diabetes mellitus. The answer is B. Graves' disease. The most likely diagnosis in this patient is Graves' disease, which is a form of hyperthyroidism. Graves' disease is an autoimmune condition in which the patient produces autoantibodies to the thyrotropin receptor, which overstimulates the release of T4 and T3, resulting in hyperthyroidism and its associated clinical manifestations: anxiety, palpitations, weight loss, diaphoresis, diarrhea, tremors, etc. Further, in Graves' disease, patients may have exophthalmos and/or line lag, which are findings that are more specific to Graves' disease than other causes of hyperthyroidism. This patient's constellation of symptoms is highly consistent with Graves' disease. Hypothyroidism is not correct, as this patient is experiencing symptoms opposite those of hypothyroidism. In hypothyroidism, one would expect the patient to feel lethargic, weak, experience weight gain, dry skin, constipation, and potentially have depression. Diabetes insipidus would present with increased frequency of urination of dilute urine, fatigue, enuresis, dehydration, and/or electrolyte abnormalities. Diabetes mellitus would not likely present in this manner. Patients are often asymptomatic at the time of diagnosis, and it would be discovered by elevated glucose or HbA1c readings on routine laboratory work. Occasionally, increased urinary frequency and dehydration, or more severe manifestations like hyperglycemic hyperosmolar noctutic coma, HHNK, or diabetic ketoacidosis, DKA, would be a presenting scenario. A glucagonoma would present with necrolytic migratory erythema, most commonly, as well as severely elevated glucose concentrations. You are the nurse taking care of a patient hospitalized for 2 months for sepsis. The patient had been receiving 40 mg of prednisone daily for the last 2 weeks for airway inflammation, and now, for the last 3 days, given symptomatic improvement, his physician lowers his prednisone dose to 5 mg daily. Today, you assess the patient and he is lethargic and hypertensive, with a serum glucose of 52 and serum sodium of 131. Which of the following is the most likely diagnosis? A. Adrenal insufficiency. B. Connecticut's syndrome. C. Surreptitious insulin use. D. Hyperaldosteronism. E. Exogenous testosterone use. The answer is A. Adrenal insufficiency. The patient had been on a prolonged course of a high dose of prednisone, a corticosteroid. When patients are on prolonged courses, and/or high doses of corticosteroids, this can cause a negative feedback cycle on the body's own intrinsic production of corticosteroids. As a result, high doses of exogenous corticosteroids, or prolonged courses of any dose of exogenous steroids should not be abruptly stopped, as the body's own intrinsic steroid production will not yet have recovered, and therefore, the patient will exhibit signs of adrenal insufficiency. In this patient's case, while the physician does not completely eliminate the patient's exogenous steroid dose, he tapers the dose way too abruptly, from 40 mg to 5 mg, which does not allow the body's own corticosteroid production to recover in time to meet the body's needs. Thus, the patient exhibits signs of adrenal insufficiency including lethargy, hypotension, hypoglycemia, and hyponatremia, hyperaldosteronism and Connecticut's syndrome. Primary hyperaldosteronism, are incorrect as these are the opposite of what is observed in this patient. In a patient with hyperaldosteronism, the patient would likely be anxious and/or have high energy, would be hypertensive, and hypernatremic, as the sodium, potassium ATPase's activity would be upregulated in the setting of excess aldosterone. Exogenous testosterone use would likely also cause increased anxiety, energy and hypertension, rather than lethargy and hypotension, as in this patient. Surreptitious insulin use could explain lethargy, hypotension, and hypoglycemia, but would likely cause hypernatremia rather than hyponatremia, as insulin upregulates the activity of the sodium, potassium ATPase, which would increase rather than decrease serum sodium. What hormone is elevated in Nclex syndrome? A. Aldosterone. B. Cortisol. C. Vasopressin. D. Adrenocorticotropic hormone. The answer is A. Aldosterone. Nclex syndrome, primary hyperaldosteronism, is hypertension due to elevated levels of aldosterone. High aldosterone causes excretion of potassium and retention of sodium, which leads to water retention and increase in blood pressure. While elevated levels of vasopressin, antidiuretic hormone, would also cause hypertension, Nclex syndrome refers to the hypersecretion of aldosterone. Which of the following genetic condition increases risk for development of diabetes? A. Turner syndrome. B. Klinefelter's syndrome. C. Down's syndrome. D. All of these. The answer is D. All of these. All of these symptoms are associated with a higher risk of developing diabetes. Turner syndrome is also known as XO, where the individual is a female, and is monosomic for the X chromosome. Individuals with Turner syndrome are also at higher risk of heart disease, and hypothyroidism, and they are sterile. Down's syndrome is caused by trisomy of chromosome 21, and involves elevated risks for mental impairment, heart disease, and certain cancers. Klinefelter's syndrome patients have the XXY chromosomal expression. They are at a higher risk than the classically male or female public for osteoporosis, hypogonadism, and cardiovascular disorders. What is the most common cause of Cushing's disease? A. Pituitary adenoma. B. Paraneoplastic syndrome. C. Renal adenoma. D. Corticosteroid use. The answer is A. Pituitary adenoma. 80% of cases of Cushing's disease are caused by adrenocorticotropic hormone, ACTH secreting adenomas of the anterior pituitary. High ACTH ends up causes adrenal hyperplasia, which leads to secretion of extra cortisol. Corticosteroid use is the leading cause of Cushing's syndrome, rather than Cushing's disease. How does insulin affect serum electrolytes? A. Insulin increases the permeability of many cells to chlorine, sodium and potassium ions. B. Insulin decreases the permeability of many cells to potassium, magnesium and phosphate ions. C. Insulin has no effect on serum electrolyte levels. D. Insulin increases the permeability of many cells to potassium, magnesium and phosphate ions. The answer is A. Insulin increases the permeability of many cells to potassium, magnesium and phosphate ions. Insulin activates sodium-potassium ATPase in skeletal muscle cells, causing an influx of potassium. Under certain circumstances, an incorrectly administered injection of insulin may kill patients due to its ability to acutely suppress plasma potassium concentrations. What mediates intracellular transport of glucose into the beta cells of the pancreas? A. GLUT4, an insulin-independent glucose transporter. B. GLUT2, an insulin-independent glucose transporter. C. GLUT2, an insulin-dependent glucose transporter. D. GLUT4, an insulin-dependent glucose transporter. The answer is B. GLUT2. an insulin-independent glucose transporter. GLUT2 is the primary carrier for glucose transport into pancreatic beta cells. It does not depend on insulin to function. It thus aids the pancreatic beta cells sense glucose levels in the blood, which are then triggered to release insulin. GLUT4 is active primarily in adipose and muscle tissue. What is the triad of presenting symptoms of diabetes mellitus in adults? A. Polydipsia, weight loss, and enuresis. B. Polyuria, weight loss, and polydipsia. C. Weight gain, enuresis, and polydipsia. D. Polyuria, polydipsia, and polyphagia. The answer is D. Polyuria, polydipsia, and polyphagia. The first onset of diabetes is generally marked by the following three signs: polyuria, frequent urination; polydipsia, increased thirst and fluid intake; and polyphagia, increased appetite. In children with type 1 diabetes, enuresis, involuntary urination, is often the first sign noticed by parents, along with unexplained weight loss and recurrent infections. What is the most common cause of primary hyperparathyroidism? A. Parathyroid hyperplasia. B. Parathyroid carcinoma. C. Parathyroid adenoma. D. None of these. The answer is C. Parathyroid adenoma. Primary hyperparathyroidism is most commonly due to a parathyroid adenoma. 80 to 90% of cases of primary hyperparathyroidism are due to parathyroid adenoma. 10 to 15% cases are due to parathyroid hyperplasia, and parathyroid carcinoma accounts for 1 to 5% of all cases. Secondary hyperparathyroidism is the result of chronically diminished levels of serum calcium. Depressed levels of serum calcium leads to a compensatory increase in the activity of the parathyroid glands. What is the most common cause of secondary hyperparathyroidism? A. Poor nutrition. B. Renal failure. C. Bone cancers. D. Pituitary tumor. The answer is B. Renal failure. Renal failure is by far the most common cause of secondary hyperparathyroidism. If kidneys are unable to convert vitamin D to its active form, serum vitamin D levels will drop. Lower vitamin D levels reduce the absorption of calcium in the intestines and reduce the kidney's ability to resorb calcium from the urine. In addition, if the kidneys are unable to adequately excrete phosphate, calcium phosphate forms, which further lowers free calcium levels in the blood. Poor nutrition is not a common cause of secondary hyperparathyroidism, though low vitamin D levels due to malabsorption can be a contributing factor. Pituitary tumors can be seen with hyperparathyroidism when part of multiple endocrine neoplasia type I, but this is not as common as renal failure. Bone cancers are more often associated with elevated calcium levels, resulting in low or undetectable parathyroid hormone levels. A 50-year-old female client is seen in the clinic for her recent diagnosis of hypothyroidism. Which of the following instructions should be included in the nurse's teaching plan? A. Explain the outcomes expected with removal of the thyroid gland. B. High protein, low carbohydrate diet and replacement hydrocortisone. C. Obtain a hemoglobin A1C test. D. The use of antiglycemic medications. E. High fiber, low calorie diet, and 5 to 6 small meals per day. The answer is E. High fiber, low calorie diet, and 5 to 6 small meals per day. Hypothyroidism usually involves weight gain, so a lower calorie diet with frequent small meals are recommended. High fiber, low calorie diets and stool softeners will help to alleviate these symptoms. Antiglycemics and hemoglobin A1C tests are indicated for diabetics. A middle-aged female client has just underwent a thyroidectomy for treatment of Graves' disease. The nurse caring for this client is aware she may need to monitor the client for what possible complication? A. Bone pain. B. Goiter. C. Oliguria. D. Tetany. E. Tetanus. The answer is D. Tetany. Tetany is a complication due to hypocalcemia which can occur if the parathyroid glands which control calcium balance are accidentally injured during thyroidectomy. Tetany is associated with nerve excitability and sustained muscle contractions, or spasms. Tetanus, bone pain, and oliguria are not associated with complications of a thyroidectomy. Goiter is a manifestation of an overactive thyroid. A 45-year-old female client with Addison's disease has presented to the client for instruction on her medication regimen. The nurse understands that the patient may require lifelong corticosteroid replacement. It will be necessary to educate the client about possible side effects of this type of therapy. Which of the following should a nurse include in her teaching plan about corticosteroid therapy? A. Monitor glucose with finger sticks to check for hypoglycemia. B. Increase sodium intake to prevent hypotension due to edema. C. Increase calcium intake to at least 1,500 mg per day with vitamin D, to help to prevent steroid-induced osteoporosis. D. The medications should be taken on an empty stomach in the morning to avoid nausea if taken with food. E. Increase intake of folic acid and B12 to prevent neurological side effects such as paresthesias of the hands and feet. The answer is C. Increase calcium intake to at least 1,500 mg per day with vitamin D, to help to prevent steroid-induced osteoporosis. Corticosteroids may lead to bone loss, especially after long-term treatment, over 3 months. Calcium and vitamin D supplementation can help prevent these side effects. The client should also be advised to start a low-impact exercise regimen if possible, and if necessary take a bisphosphonate drug. You are caring for a patient who is started on clindamycin, ketorolac, prednisone, lisinopril, and simvastatin. After receiving multiple doses of each of these medications, you notice that the patient's blood glucose is 205 mg per deciliter. Which of these medications is known to cause hyperglycemia? A. Ketorolac. B. Lisinopril. C. Simvastatin. D. Prednisone. E. Clindamycin. The answer is D. Prednisone. Of all the medications listed, prednisone is the only medication that is known to cause hyperglycemia. Prednisone has a number of side effects including hyperglycemia, acne, headache, restlessness, insomnia, nausea, vomiting, and weight gain, among others. Clindamycin's side effects include diarrhea, including Clostridium difficile, and less commonly nausea, vomiting, and abdominal pain, among others, but not hyperglycemia. Ketorolac's side effects include renal toxicity, tinnitus, heartburn, diarrhea, and abdominal pain, among others, but not hyperglycemia. Lisinopril's side effects include hypotension, lightheadedness, angioedema, and barky cough, among others, but not hyperglycemia. Simvastatin's side effects include muscle pains, aches, muscle weakness, and less frequently confusion, and electrolyte disturbances, but not hyperglycemia. You are the nurse taking care of a patient with type 2 diabetes mellitus. The patient is hospitalized for pneumonia and switched from his home medication, metformin, to sliding scale insulin, while inpatient. You explain to the patient that the specific reason is which of the following? A. To prevent lactic acidosis while hospitalized. B. To prevent headache while hospitalized. C. To prevent myocardial infarction while hospitalized. D. To prevent depression while hospitalized. E. To prevent stroke while hospitalized. The answer is A. To prevent lactic acidosis while hospitalized. A known side effect of metformin use is development of lactic acidosis, a form of metabolic acidosis. Patients who are hospitalized, especially if hospitalized for infections, like pneumonia, are independently at an elevated risk of developing a lactic acidosis. As such, to minimize the risk of lactic acidosis, a modifiable risk factor, metformin use, is frequently temporarily discontinued while inpatient. Patients on metformin are frequently switched to sliding scale insulin as inpatients, as this allows for adequate glycemic monitoring, titration, and control. Once they are stable for discharge and the cause of their hospitalization is addressed and treated, most can be safely discharged home on metformin without issue. While numerous measures are carried out while patients are hospitalized to prevent myocardial infarction, stroke, headache, and depression, the switching of metformin to sliding scale insulin is not performed specifically for any of those reasons. Which of the following is true of type 1 diabetes? A. Patients develop insulin resistance. B. Patients are typically overweight adults. C. Patients typically present in diabetic ketoacidosis. D. Patients do not require treatment with insulin. The answer is C. Patients typically present in diabetic ketoacidosis. Type 1 diabetes is an autoimmune process that typically presents in young children in the form of DKA, diabetic ketoacidosis. This potentially life-threatening condition is treated with IV insulin. Type 2 diabetes is insulin resistance, and is found in older adults, typically those who are overweight. The nurse is caring for a patient who is to receive a fasting blood glucose test. The nurse does all of the following to prepare the patient except dash. A. Restricts meals 4 to 8 hours before the test. B. Marks the patient in PO 2 hours before the test. C. Instructs the patient to refrain from the use of hard candy. D. Instructs the patient not to use any gum or breath mints. E. Stops the patient's D5 0.45 IV maintenance fluid. The answer is B. Marks the patient in PO 2 hours before the test. The patient should refrain from ingesting any material that may contain sugar prior to a fasting blood glucose. However, is not necessary for a patient to be labeled in PO as they are still able to ingest water. All other preparations should be made. The nurse cares for a patient newly diagnosed with systemic lupus erythematosus, SLE. Which of the following is a characteristic sign of SLE? A. Pain during exposure to cold. B. Blood in urine. C. Arthritis and joint swelling. D. Lesions on extremities. E. Butterfly rash across bridge of nose and cheeks. The answer is E. Butterfly rash across bridge of nose and cheeks. The most characteristic sign of SLE is a butterfly rash across the bridge of nose and cheeks. The others listed are also signs and symptoms of SLE, but the most well-known sign that is specific to SLE is the butterfly rash. Arthritis and joint swelling, hematuria, lesions on extremities, and pain during exposure to cold, Raynaud's phenomenon, may be signs of other diseases.